Okay, so one of the things I want to cover here, Mike Karegeannes again, Freedom Physical Therapy Services and TMJ, TMD Physical Therapy Specialist, is something that we call the Cervical Flexion Rotation Test. It's actually been a very well researched objective test that we can use in the clinic to help tease out if there's rotational problems between the first cervical vertebrae, the atlas, or the second one, the axis. 50% of our cervical rotation actually comes from C1 and C2. One of the things that we know from the research is that when we do this flexion rotation test, the side that tends to be more restricted, so as you turn their head, and if they're more restricted going, let's say, to the left, it tends to coincide quite highly and correlate with the side that they will tend to have cervical-related headaches. The other thing we're seeing now, as Toby Hall and some of these others are doing some great research out there, we're also seeing a higher positivity rate, not only in conjunction with people with cervical headaches, but also with temporomandibular disorder. So this is a really important test that we use or should be used in the clinic when you are assessing your temporomandibular headache migraine type patients. It is interesting. In your migrainous patients, however, this test tends to be negative, so you can't necessarily determine. But I will say almost majority of my migraine patients also have fairly persistent cervicogenic, temporalis type headaches, right? So if we can tease out and remove a layer of those headaches, a lot of times we'll disrupt the frequency and intensity of their migraines. So there are other things I will do palpation-wise. Again, as I mentioned in some of my other videos, I really like to trust my fingers and my hands and get a sense of what kind of rotational changes might I be feeling between C1 or C2, and then see if that corresponds with a clinical exam. But the basic idea of the cervical flexion rotation test, and again, assuming people are relatively pain-free, is to bring the patient's head all the way up into a flexed position as much as you can. So I really try hard to almost make sure with their mouth closed, their chin is resting pretty close to the top of their chest. And I will actually use my belly a little bit to try to hold them, or at least certainly make sure I've got them pinned fairly snug. And then if you can imagine, if I could put an axis directly through the top of her skull here, that's the rotational line I want to go around. So I'm going to keep her chin firmly pressed down against her chest, and I am going to rotate her head first to the left. And what I'm trying to get a gauge is, roughly where. Now, I could use a goniometer and different things. I try not to get too fancy. I really rely on my hands to get a sense of restriction and tightness, but a visual observation of limitation. So ideally, you'd like people to be able to rotate maybe towards their axilla here. So she's a little limited to the left. And then I'm going to check to the right. And one thing you may or may not notice, it's hard to tell from the camera angle possibly, but she definitely rotates better to the right. So I would say she has about a 10-degree, maybe even 15-degree loss of rotation to the left between C1 and C2 versus the right. And I would want to work hard to treat that out. But then, if Molly happened to have headaches, usually almost about a 90% correlation that it would be consistent with headaches on her left side. And then there are treatment techniques that we would do for that. A variation of that, and I find I have to use, so for my hypermobile patients, so patients that have excessive elasticity in their tissues, excessive cervical spine mobility, they also tend to have excessive joint opening and other things that occur in the jaw. Sometimes that test doesn't give you as accurate information as you would like, so I default to doing something a little different. In this case, I will bring their head all the way to their right side, so almost trying to get their ear on the right to touch their shoulder on the right. And then I will keep them locked in this position as I rotate Molly's head to the left. And again, getting a sense of what does it feel like at the end? Does it feel soft tissue-y? Does it feel hard and abrupt? And what does that quality and range of movement look like? Then I will compare. I'll bring them back to the center. I will bring Molly all the way to the left side, and maybe to stay out of the view of the camera, just ignore my body position, but I would tend to be in line with her. And I would come here and assess. And again, to me, there's just no question. She's freer turning to the right here at C1, C2 than she is when I come all the way over this way and assess. And there's just definitely more of a restricted, blocked type of movement. And then from there, you know, my techniques could be, there's some osteopathic techniques called muscle energy. I like to manipulate the cervical spine, so if that were appropriate, do some good joint manipulation. And then please, you know, we can't ignore that there are muscles, right? So there could be any other factors, the sternocleidomastoid, the trapezius, the levator muscle. There could be muscular components too that we need to tease out through stretching, you know, maybe dry needling, all these other different techniques so that we really help resolve the situation and restore as much symmetry and quality of movement to her C1 and C2 that we can, assuming, again, a fairly healthy individual, otherwise that there's no significant rheumatoid arthritis or osteoarthritis in those joints between C1 and C2, which can occur. So thank you very much.